Primary snoring is essentially the acoustic result of fluid dynamics, smooth, steady airflow suddenly colliding with a severe bottleneck. This phenomenon is incredibly common. Because of that, both patients and clinicians frequently dismiss it as a harmless nighttime nuisance. But that noise is a mechanical symptom. It is the literal sound of internal soft tissues violently vibrating against one another during sleep. This diagram shows the structures responsible for vibration: the soft palate, uvula, tongue base, and pharyngeal walls. When this airway structurally narrows, air velocity increases. The smooth flow of oxygen fragments into chaotic turbulence as it forces past these tissues. Therefore, a patient's snoring is definitive proof of measurable mechanical resistance within their upper respiratory tract. We classify primary snoring as a benign condition, yet the sheer volume of the turbulence directly fragments the sleep quality and spikes the fatigue levels of bed partners. Because snoring proves airway instability exists, the immediate duty of the clinician is to determine if that instability has crossed into pathology. The severe pathological counterpart to primary snoring is obstructive sleep apnea, or OSA. To safely diagnose primary snoring, a clinician must explicitly rule out OSA by proving the patient is not experiencing three specific physiological failures. Why does this mechanical failure happen exclusively when a patient loses consciousness? The answer lies in the physiological baseline of sleep itself. As the brain cycles down, global muscle tone naturally decreases throughout the entire body. This cross-section shows how loss of muscle tone affects the airway. A rigid, circular waking passage compresses inward into a collapsible, irregular oval. As diameter shrinks, airflow resistance increases. Air forcing through this narrowed space causes soft edges to rapidly vibrate. This soft tissue collapsibility worsens progressively during the deeper stages of sleep, directly correlating to louder acoustic volumes. Primary snoring is an anatomical vulnerability directly unmasked by the neurological state of sleep. Certain external variables act as force multipliers on an already collapsible airway. Structural factors like obesity and a large neck circumference add dense external physical weight that continuously pushes inward on the pharyngeal walls. Chemical depressants like alcohol and sedative medications artificially force muscle tone lower than normal sleep states. Then there is the critical role of body position, specifically lying flat on the back, known as the supine position. This diagram shows the mechanics of supine sleep. Gravity applies a direct downward vector, pulling the heavy base of the tongue tight against the back wall of the throat. Diagnosing a snorer requires auditing their lifestyle and sleep position, as these exact external factors often push a benign airway into a state of critical narrowing. Clinical history alone cannot confirm safety. Definitive differentiation requires objective data from a polysomnography, or PSG, sleep study. This dashboard compares parameters during a sleep study. First, airflow. In primary snoring, airflow is a continuous wave. In OSA, the airway fully collapses, resulting in complete apneas, shown by the flat line. Next is gas exchange. Because the primary snorer maintains continuous airflow, their blood oxygen remains stable. The OSA patient experiences deep, jagged drops in oxygen directly caused by the apneas. Finally, sleep architecture. The primary snorer sleeps straight through the turbulence. In contrast, the OSA patient's brain detects the oxygen drop and triggers a sudden cortical arousal, a chaotic spike in activity, just to force a breath. Because their sleep architecture remains unfragmented, the primary snorer wakes up rested. They do not suffer from the severe, excessive daytime sleepiness that characterizes OSA. Primary snoring is definitively characterized by the presence of noise, combined with the absolute absence of apneas, desaturations, and arousals. Once OSA is completely ruled out, treating primary snoring becomes a straightforward process of reversing that specific mechanical resistance. Positional therapy uses wedges or behavioral conditioning to prevent supine sleep, explicitly negating gravity's downward pull on the base of the tongue. Nasal management utilizing adhesive strips or sprays resolves upstream congestion. This heavily reduces the vacuum effect pulling downward on the lower airway. This profile view shows the mechanics of oral appliances. They mechanically grip and slide the lower jaw forward, physically widening the pharyngeal airway space behind the tongue. Lifestyle modifications tackle the external variables. Weight loss removes structural crowding from the neck, and avoiding alcohol preserves essential baseline muscle tone. Every valid clinical treatment for snoring operates by achieving one of two things: physically increasing the airway diameter or improving muscle rigidity. The long-term prognosis for primary snoring is often highly stable and heavily responsive to these exact types of mechanical interventions. However, a benign airway can degrade. As patients age, gain weight, or lose tissue elasticity, airway resistance naturally climbs over time. Clinicians look for specific criteria to trigger a reevaluation: the sudden onset of daytime sleepiness, or bed partner reports of witnessed apneas. While primary snoring lacks the physiological destruction of true sleep apnea, it must be monitored as the first observable warning sign of sleep-disordered breathing.